consultants. But tonight we're going to be talking about pharmacogenomics, and I'm honoured to be able to invite Professor Sir Munir Pirmohamed, the Chair of the NHS Pharmacogenomics UK. Thank you so much.
Thank you very much for the invitation. I'm glad to see so many of you over here. I would have thought that you'd all be watching the Arsenal match right now. I am an Arsenal supporter, by the way. So you need to tell me when they score, please.
You don't want to know.
No. Yeah. Mixed blessings. So I thought I'd just start off with some disclosures so that people are aware that in terms of what I do, all the studies I do are funded via government agencies, funding agencies, and the EU Commission. But I also sit on government advisory committees, so that you know exactly where I'm coming from. So the problem that we have in the way we use drugs at the moment in the NHS and in any healthcare system is not just the NHS. By the way, NHS is a fantastic organisation. Anybody who criticises the NHS is doing the wrong thing. I've worked in the NHS for 30 years, so you know. Everything that we do in any healthcare system is beset by problems of variability in drug efficacy. The vast majority of drugs, more than 90% that we use today, work only in 30 to 50% of people. And particularly in psychiatry, you have to give a drug, and then you wait for the response, and then you give the second drug, you have to wait for the response, and so on. And by which time the patient's getting worse, they may be getting side effects, etc. So we need to think about how we can get the right drug to the patient a first time to get the best efficacy. The opposite of efficacy is obviously the safety aspects and adverse drug reactions. So 6.5% of all hospital admissions to the NHS hospitals are due to adverse drug reactions. And when you are admitted to hospital because of a disease, your pathology is changing, your physiology is changing, the doctors are changing your drugs all the time to be able to improve your condition. 15% of patients in hospital will suffer some kind of adverse drug reaction. And we did a calculation that if we were to extrapolate to the NHS bed base at the moment, there are 8,000 NHS beds occupied by patients with adverse drug reactions at a cost of 1 billion. In fact, there was Jeremy Hunt did a news conference about 2 weeks ago, and after a report was published by an economic think tank, which actually said that the cost of adverse drug reactions is about 1.6 billion to the NHS. So our figure was more conservative. So genetic factors are important, and that's what I'm here about. But I think it's important to say that I'm not completely hung up about genetic factors. There are many other factors which determine whether a patient gets an effect from a drug or gets an adverse effect from a drug. Some are environmental, some are clinical, some may be related to poor prescribing, etc. We do not know what the overall genetic contribution is. Some people have suggested it's about 30 to 40%, but I think that's a very poor estimate. The genetic effect certainly varies according to drug and response. Some drugs have a genetic effect which is almost 100%. Some may have a genetic effect which is about 10%. And we need to be able to get the data to see where it's relevant to be able to use genetic testing. And that's what my research does, is try to understand what the genetic factors are, what the contribution is, and how we can then implement this into clinical practice. So what we're talking about today is really pharmacogenetics. And this is not a new term. It was defined by Friedrich Vogel in 1957. And he said it was a study of variation in the DNA as it related to drug response. In 1997, the editor of Nature Biotechnology, Andy Marshall, coined the term pharmacogenomics, which is much more looking at the whole genome, looking at not only DNA and RNA. And these kind of definitions have now been validated by the International Conference on Harmonization in November 2007. And clearly what the pharmacogenetics and pharmacogenomics tell you is that there is variability. And the variability resides in the fact that 99.9% of our human genome is exactly the same, irrespective of where we come from in the world, but 0.1% is different. So if you have 3 billion bases in your human genome, 0.1% difference is actually quite a lot. It's 3 million bases are different. And those 3 million bases determine how tall you are, what color eyes you have, and also your response to drugs. And we need to be able to understand that 0.1% so that we can actually improve what we do in terms of medicine, not only in terms of what we use, but also predictions of who's going to get a particular disease, but also in terms of prognosis as well. So how does pharmacogenetics affect the way we handle drugs? Well, drugs are handled in the body generally in terms of pharmacokinetics. That is, if you give a drug orally, it's absorbed through your small intestine usually. It's then distributed through the circulatory system to the different parts of the body where it needs to go. And then the body has to get rid of it in terms of metabolism. That usually occurs in the liver. And the kidneys are the major excretory organs to get rid of the drugs. So all of these processes are variable amongst us. So everybody in this room will have variability in absorption if I was to give you the same drug, metabolism and so on. And that can be affected by environmental factors, genetic factors, etc. that are there. Then, so the other aspect of how drugs work in the body is something called pharmacodynamics. This is what the drug does to the body. So pharmacokinetics is what the body does to the drug, and pharmacodynamics is actually what the drug does to the body. It acts on cells, it acts on organs, it acts on receptors, ion channels, nucleic acid and so on. And again, that's also variable, and it's related to the same kind of factors, environment factors, genetic factors and so on. So if you want to develop personalized medicine, it's not just worthwhile just looking at genetic factors, obviously that's important, but you need to look at all different factors and put them together. And the concept that we have for personalized medicine is shown here on this slide. I'll go through this. At the moment, everything that we define in medicine is based on definitions which were created in the late 19th century, early 20th century. It's a phenotypic definition. We say this is diabetes or type 2 diabetes. But really, we know that as we move further and understand more about disease, we start to develop a molecular definition of disease, and we can start stratifying the disease. So type 2 diabetes is no longer just one disease, it's actually many different diseases because of the molecular definition. And as we move forward with more knowledge of diseases that occur for patients, then we will start developing new taxonomy of disease. I think that's going to be the next real revolution in medicine, is where we have a completely new taxonomy of disease. So you are going to have to deal, and this is the complexity of those who are treating patients, and not only diabetes, type 2. Can you tell them I'm busy? Sorry. So you're going to have to deal with lots of sort of new knowledge in terms of taxonomy of disease. It's going to be ulcerative colitis, type A, B, C, D, E, F, etc., rather than just ulcerative colitis. Even when you have strata of disease, you're going to have variability because of the factors I've just shown you, and that's called pharmacogenomics. And this is what I'm going to talk about mostly. But the biggest issue that we need to look at actually is environmental factors as well. What do patients do? Patients do different amounts of they eat different things, they drink different amounts, they smoke different amounts and so on, and all that affects the way drugs work. And if you want to go from the bottom of the pyramid right to the top, this is where we will need to be if we're going to practice personalized medicine. And it's going to be a long journey. It's not going to be an easy journey. It requires multiple stakeholders to work together. It's not just going to be related to NHS doctors, academics. It needs industry, academia, NHS, regulators and so on to work together to achieve this goal. Now, pharmacogenetics, although I said the term was defined in 1957, actually is much older than that. The first example of pharmacogenetics was actually from Pythagoras in 6th century BC. And if you have got a very boring Sunday afternoon, please look him up on Google, and you'll find lots of things about Pythagoras. And one of the things he wrote about was that you should be far from flour beans consumption. And he held that belief so strongly that he was being chased by a rival army of soldiers, and he refused to cross a field of beans in ancient Italy in Cretonia, and he was killed. And people wondered why that is. Maybe because These things look like testicles and you should be eating testicles, or maybe they cause flatulence, etc. However, the main reason for that is that in some Mediterranean populations, and he was based in a Mediterranean country, the patients can develop a disease called favism when they eat fava beans, and that can cause red blood cell hemolysis. Your red blood cells just burst open, your hemoglobin pours out, it goes and blocks your renal tubules, and you get renal failure and die. And that can still happen now when people are eating fava beans and so on in certain parts of the world. Now you may say, why am I telling you about fava beans? Well, actually, this particular problem here is related to a deficiency of an enzyme called glucose-6-phosphate dehydrogenase. Okay, and glucose-6-phosphate dehydrogenase is the commonest human enzyme deficiency. And it's relevant for drugs as well. So if you look at G6PD with the drugs such as antimalarials, so here's a drug which was produced for the treatment of malaria called Lambda. It was a combination of chlorproguanil and dapsone, and it was as effective as other antimalarials out there, but the important thing was it was cheap. People in Africa can't afford drugs. It was literally a few cents a day, and that's how much it cost. But the problem is that when it was given to the African populations, because they had deficiencies in particular G6PD genes, and that led to hemolysis, and therefore the drug had to be withdrawn because there was no way of testing that in the field. And so we lost a perfectly good drug because we weren't able to identify people who were more susceptible. And in the future, what we should be doing is actually being able to test these individuals beforehand so that you can actually give people the drug that will work at an accessible and effective cost. So I'm going to take you through 3 different areas. The first is efficacy in terms of cancer, non-cancer treatments, and pharmacogenomics may be important. The second is in terms of precision dosing. And the third is in terms of safety. And I'll finish off by telling you about a big study that we're doing at the moment in Liverpool in terms of really trying to preempt in terms of genotyping and provide genotyping at the point of care. So if you look at efficacy, cancer is the poster child for pharmacogenomics. There are many, many different mutations which have been identified within the tumor genome. Remember, patients who have cancer have 2 genomes. One is the genome they were born with, and the other genome is the genome in the cancer. And the genome in the cancer is dysregulated, it has many mutations, and some of those are driver mutations. And if you can identify the driver mutation, then you can develop a drug which may be able to cure that cancer or treat that cancer. An example of this is shown in this slide here. In a patient with metastatic malignant melanoma, they were able to sequence that gene. They were able to find a mutation in a gene called BRAF, which is a tumor suppressor gene. They were able to then identify what that mutation was and develop a drug which was able to treat that particular mutation. And 2 weeks later, the patient's tumor had disappeared when they gave them that particular drug. The problem with that is that cancer is a hugely complex disease with complex biology, and the tumor comes back because of secondary mutations. And the challenge now for cancer is how you give multiple therapies at the beginning so you get long-term, durable, sustained responses, and long-term survival improves as well. Clearly, there are many things which are going on. One of the things I think that's going to be really important in terms of precision medicine cancer is the ability to be able to detect cancer before it appears clinically through doing a blood test. And this is through new next-gen sequencing technologies. And if we can do that, we can actually screen populations before the cancer becomes clinically evident, and you can then treat patients, removing the cancer and cure them. The chances of cure are much greater the earlier you catch cancer. If you catch cancer later, by the time cancer is clinically evident, the cancer will be at least 10 to the 12 cells. When it gets to 10 to the 13 cells, a patient dies. So if you can catch cancer at 10 to the 10 cells, that is when it will not be clinically evident and you may be able to cure it. And those kind of tests where you can actually identify cancer even before it's appeared through blood tests, so-called liquid biopsies, I think is going to be one of the major growth areas in the future. So apart from cancer, there are many other areas where a pharmacogenomic and drug design and drug discovery is making an impact. So here I'm going to give you 2 examples, which are non-cancer. First is cystic fibrosis. Cystic fibrosis is the commonest autosomal recessive disease in Caucasians. 1 in 2,500. The gene was identified in 1987 on chromosome 7. It's a mutation in a gene called cystic fibrosis transmembrane regulator. The commonest mutation is something called delta 508, which appears in 75% of populations. So there are now, through the work that's been done over many decades, there are at least 1,000 different mutations in patients with cystic fibrosis in this particular gene, but this delta 508 is still the commonest, 75%. If patients have cystic fibrosis, they get lots of different problems affecting their lungs, recurrent infections, their liver, pancreas, etc. And those are all shown there. And clearly, people have been trying to look for ways of being able to treat patients with cystic fibrosis, including gene therapy, but that has been not as effective as one was hoped. So this particular company and these two individuals working for a company called Vertex were able to, using a group of 200 scientists looking at 600,000 compounds and also doing some in silico screening of 2.7 million compounds, were able to identify 3 possible candidates, and then they settled with this particular candidate called ivacaftor. And ivacaftor is now available in the NHS and in many other healthcare systems. And ivacaftor targets one particular mutation, at that time anyway, which is called G551D, which only affects 4% of cystic fibrosis population. It doesn't affect the 75%, it only affects the 4% of cystic fibrosis population. But the effect in that 4% of cystic fibrosis patients who've received ivacaftor has been fantastic. Their life has been transformed by having a drug which actually acts on their mutation, with the changes in the lung function much greater than has been seen with anything else before. And that tells you about genetic targeting in terms of improving things. So, based on the knowledge of that particular mutation and how it causes problems, the sort of indications for this particular drug have been expanded in 2014 to be able to look at other mutations. And so once you understand how a mutation affects a particular function of a particular gene and the protein, you can then look at other mutations which may be similar and therefore expand the indication. So the problem, I guess, people are worried about this particular drug because it costs a lot to the NHS. I think the cost is, I don't treat patients with cystic fibrosis, but the cost is between 150 to 200,000 pounds per patient per year. But for that innovation, it is still hugely effective. They stop coming to hospitals with recurrent infections and so on. So over the long term, it may still be very cost effective. So, but despite that, I think we can still actually develop much cheaper drugs as well by actually understanding the basis, the genetic basis of disease. So here's a disease which is unfortunately rapidly fatal when it develops in children. It's called childhood motor neuron disease, Brown-Violletto-Van Leer syndrome. It causes deafness, speech problems, swallowing problems, limb weakness, breathing, and when children develop it, soon after they develop it, they can die from that disease. It's rare, fortunately, only about 60 cases reported worldwide. And work which was undertaken at UCL in London through exome sequencing was able to identify that there were mutations in 2 particular genes which are called SLC52A2 and 52A3, and these particular genes are transporters. They transport riboflavin, which is vitamin B2, into the cell. You need vitamin B2 for your mitochondria to work properly. If you can't get vitamin B2 into your mitochondria don't work properly, and therefore your nerve cells die. And so because they were able to show that this was related to riboflavin transport, what people have started to do is to treat patients with high-dose riboflavin, or have developed riboflavin esters, which can bypass this block and get into the cell and actually treat the patients. So what is happening with these patients is now, for the first time, they've got a vitamin that you can buy from a health food shop out there that can actually treat a fatal disease. And the children are living longer and sometimes have normal lives. And that's the power of kind of when you can actually identify a particular mutation. And clearly the 100,000 Genomes Project in the UK is a transformation project. It is already having a major effect in many areas, with novel mutations being identified in many patients, which are leading to treatments. So that's efficacy. Let me just go through dosing. So Paracelsus in the 16th century basically said that poison is in everything, nothing is without poison. the dose is what makes it either a remedy or a poison. Now, you'd have thought in 500 years we'd have learned from that, but unfortunately we haven't. And what we tend to do is to treat the dose as being the same as exposure. And what I mean by exposure is that if I give everybody in this room the same dose of a drug and then measure your blood for that particular drug, there'll be huge variation in the concentration of that drug in your bloodstream, and that's called exposure. And that varies. And it's exposure which is important because it determines whether you respond well to the drug or respond badly to the drug. And you can see this is an HIV drug. And in terms of, if you look at different time points here, so for example, the 2 hours, you can see there are some individuals with very low concentration of the drug, despite the fact that they've been given the same drug dose, and there are some individuals with very high concentration of drugs. Similarly, at 12 hours, you can see. So those individuals here with a high concentration of drug may be more prone to developing side effects, while those individuals here at the bottom are more likely to develop lack of efficacy. And so what we need to do is to overcome this so that we can actually give them the right dose at the right time so the patients actually get the efficacy response rather than no response or toxicity response. And this is beginning to happen. So here's a drug which was licensed by the FDA and the European Medicines Agency, and it's used for the treatment of Gaucher's disease, which is rare disease, and it's metabolized by an enzyme called cytochrome P452D6. Now, cytochrome P452D6 is absent in 8% of the UK population. So if what they found, and they did the work on this, they found that individuals who had absence of this particular gene, and they're called poor metabolizers, had much higher levels, higher exposure, while those individuals who are extensive metabolizers, which is most of you in this room, will have kind of normal exposure, if you like, in inverted commas. And from this, they were able to say to the regulatory agencies, look, if they're a poor metabolizer, we should give them half the dose of those individuals who are extensive metabolizers. And that's what happens now in practice. And it means that they are getting the same exposure, despite the fact that these individuals are getting half the dose of those extensive metabolizers. And that's the way we should be going, and that's kind of, a new drug which has been licensed. And there are many examples of drugs where we should be doing that. So let's look at a couple of them here at the bottom of the slide. First one is codeine. Now, codeine is an analgesic drug. It's actually a prodrug. It needs to be converted to morphine to work. Now, if you give a patient codeine and they don't respond, it is possible that they may have a problem in converting codeine to the morphine, because that requires cytochrome P452D6. So 8% of the UK population will not respond to codeine in terms of efficacy. They'll say, I've still got pain. And if it's your partner and they've still got pain, don't call them a wimp. It may actually be a biological reason why they're not actually having any pain relief. So that's very important. Similarly with psychiatry drugs, there may be some patients where you can't metabolize it and you give them standard dose, they get very high levels of the psychiatry drug, and that causes adverse effects in those individuals. Interestingly, there are people in the population who have more than 2 copies of the gene, and they're called ultra-rapid metabolizers. That's 2% of the UK population, but actually if you go from the UK towards the equator, that frequency increases. So in Ethiopia, the ultra-rapid metabolizers, that is, they have more than 2 copies of the gene, is up to 29%. Okay, what does that mean? That means that if you have 3 copies of the gene, you're going to metabolize the drug much more rapidly, and you may need a higher dose. So those patients with psychiatry drugs who may not be responding, and are called resistant patients with resistant depression, may actually not be getting enough levels of the drug in their bloodstream, and what they need is higher doses to be able to help them rather than lower doses. And that is an issue that we do need to tackle, and I know that there are some psychiatrists in the room who may be doing that already. So the area that in terms of precision dosing, which affects a large proportion of the population, is with warfarin. And warfarin is taken by 1% of the UK population. Some people require half a milligram a day, some people require 20 milligrams a day. So there's 40-fold variability in dose requirements. And although we have a blood test called INR that we monitor, we try to give between 2 and 3, unfortunately, many patients go above 3, and when they go above 3, there's a higher risk of them bleeding. This is an 82-year-old patient who was given warfarin for 6 weeks and came in with a calf hematoma and was admitted to hospital, and then stayed in hospital for 6 weeks trying to recover from the calf hematoma. And what we want to do is to obviously avoid that because not good for the patient, and it's not good for hospital bed usage and so on. So work which has been undertaken by a lot of people around the world, including ourselves, and this is a UK-based cohort, has been able to show that there are genetic factors which determine your dose of warfarin you require every day. So if you look at the clinical factors, and that's been known about for a long time, so as you get older, you need a lower dose of warfarin. So that's because as you get older, your liver gets smaller. Okay, so that's something for all of us to look forward to, I guess. And if you get heavier, then and our population is getting heavier, then you need a higher dose of warfarin. If you're given some concomitant drugs, that can also affect the amount of warfarin you require. But actually, when you take all these clinical factors together, the total amount in terms of variability it predicts is quite small. But then when you actually look at genetic factors, these are much more important. So here are the two genetic factors. One is cytochrome P452C9, and that is the enzyme that metabolizes warfarin, and that accounts for about 16% of the dose variation. And the other one is vitamin K peroxidase complex, which is an enzyme inhibited by warfarin, and that accounts for 26% of the variability. So when you put all this together, you can actually predict about 60% of the dose variability for warfarin, which is very good, actually, because we'll never be able to get to 100% ever in personalized medicine. But I think if we get to from where we are now, which is about 10% to 60%, that's a major improvement. So what did we do when we found this? Well, we developed an algorithm, a dosing algorithm. That dosing algorithm took into account all these factors: age, height, weight, interactive medication, and the genetic factors. Now, when you develop an algorithm, people will say, well, what does it mean? You haven't shown us it's any good. So how are you going to show that? So you have to do a randomized control trial, which is what we did. So the randomized control trial was sponsored by the European Commission. And what we did was to randomize 454 patients to a genotyped arm or the standard care arm. And this trial was undertaken in Liverpool and Newcastle and in Uppsala and the surrounding sites in Sweden. And so if you look at the standard care arm, the standard care was that you get 10 milligrams day 1, 5 milligrams day 2, 5 milligrams day 3. And that's the standard care that occurs in most NHS hospitals. So what we did for the genotyped arm, you took a small blood sample from them, just 1 ml, and you put it into this machine. And this machine then told you what the genetic test results were within 2 hours. Okay, so if you get the results with genetic tests over 2 hours, you could then put that into the algorithm. So the algorithm was web-based. We put that genetic test results into the web-based algorithm, and that told us what the dose should be for the genotype-guided dosing arm for that particular patient. So a patient could get 6, 4, 2 instead of 10, 5, 5, for example. And so we then followed them up for 3 months. And the primary outcome measure that we had was the percentage of time within the therapeutic range. The therapeutic range for warfarin is between 2 and 3 for the first 12 weeks following initiation of therapy. And so what we got is a positive effect of genetic dosing. So let me just take you to the control arm first of all. This is the arm where we give 10, 5, 5. And what we found was a very good time in range, 60%. Now that doesn't happen normally in clinical practice. This was a randomized controlled trial with carefully monitored protocol, and we achieved a fantastic 60% time in range. But despite that improvement in time in range in the control arm, we still beat it in the genotype guided dosing arm with a 67% time in range, and this was statistically significant. And that has, and if you look at the people going outside the range in terms of having an INR above 3, then it was much less likely to occur in those who were genotyped compared to standard dosing. And so the next thing that people ask was, well, is this cost effective? Are you going to be able to save money for the NHS when you do this? So you do some cost effectiveness work, and we were able to show that in the UK it was highly cost effective. The incremental cost effectiveness ratio is £6,700. NICE accepts an ISA of £20,000 to £30,000, so it's well below the cost effectiveness ratio here in £20,000 to £30,000 threshold, suggesting this is highly cost effective. So what have we been doing since then? Well, we've worked with LGC, the company that developed the original test, and this is an LGC test. They've got a new technology called ParaDNA, and now what happens with this particular test is that you only have to take a mouth swab in our clinics, you put it into the well, and you get the result in 45 minutes. Not 2 hours, but 45 minutes. And that is now being done by nurses in clinic and provided to the patient in terms of the dosing for warfarin and so on. So let me go into the last part of this, which is looking at the serious adverse drug reactions. And what I mean by that are reactions where your skin blisters off. So toxic epidermal necrosis is when you have 30% of your body surface area blistered. That's like having third-degree burns affecting more than a third of your body surface area. And if you get that, a third of patients will die from that. So it's a serious reaction, fortunately rare, but why do some patients get this kind of serious reaction is what we're trying to look at and trying to identify. And some patients can get, for example, liver failure. And so we've been particularly interested in a region of the genome called the human leukocyte antigen area, which is the Myogenes histocompatibility complex. And this is on a short arm of chromosome 6. This is the most polymorphic region of the human genome. It's become most polymorphic region because this is the region of the genome that protects you against infections. We are all exposed to many different microbes which are always mutating, and we need to protect ourselves against those microbes. And this, through evolution, has developed into the most polymorphic region to be able to protect us against those microbes. But unfortunately, that variability also predisposes certain individuals to these serious reactions. And so what we've been trying to do is to work out what particular HLA alleles are important in terms of these reactions. So the best example of that is with a drug called abacavir, which is a drug which was used in, is still used in HIV. It's very effective in HIV in combination with other drugs. However, abacavir causes a serious reaction affecting the skin, liver, your respiratory system in about 7% of individuals. And work undertaken in Australia, in the United States, and by ourselves are able to show there was a particular gene called HLA-B57.1 which predisposed to abacavir hypersensitivity. And we asked the question, does genotyping for this particular gene, HLA-B57.1, prevent abacavir hypersensitivity and would be cost-saving for the NHS? And we did some cost-effectiveness modelling, and we were able to show that it would actually be cost-saving for the NHS. It would prevent these serious reactions. And we published this in 2004. By 2006, every NHS clinic in the UK was using this genetic test. And the net effect of that has been dramatic. Before the genetic test was used, the incidence of the abacavir hypersensitivity was 7%, and since it's been used, it's less than 1%. It's virtually disappeared from the NHS, this particular serious reaction. And that's a major impact. This is really genetics in action, and it shows that genetics can actually have an effect. So this is one example, but actually since the beginning of the century, we're only 18 years into the century, there have been at least 24 different genetic associations with HLA alleles with different drugs and different types of reaction. Those which cause the sort of skin rashes, those that cause liver failure, those affect muscle, those affect bone marrow, etc. And they're all listed on here. And actually this is out of date now. There's actually probably about 30 different HLA alleles which have been identified. And so the big question that we wanted to ask was, well, how can we actually help people in terms of trying to genotype for this? Because these are not very widely available. They're available in immunology labs. You send those tests off to immunology labs, and you may ask for one particular test. It may take 2 weeks to get the result. As a doctor, I want to prescribe a drug to my patient quickly. I don't want to wait 2 weeks, and that is a barrier to implementation of these tests. So what we have done is worked with, got funded from NIHR, the National Institute of Health Research, and worked with a small company who had patented technology called Mr. Spot here. And in that, they have small wells in there. And in those wells, there are sequence-specific oligonucleotides spotted on the base of the wells, which allow you to be able to genotype individuals for those particular HLA alleles. And then you can see them on the computer screen in terms of what the result is. And the idea behind this particular panel, and we've developed this panel which actually is able to look at all of these particular HLA alleles, is that you can type individuals very quickly for this particular polymorphism you're interested in, the HLA allele. But actually, we all get older. And unfortunately, as we get older, we may need other drugs which are also on the panel. So you need to test for one particular HL allele, but you can get the results for the other HL alleles, and you can keep them on your electronic health record. So you don't need to test more than once. It's there available for you. And this genetic panel is going to be cheaper to the NHS than individual locus tests. Okay, and that's the aim that that we've got. In addition, what we've also tried to do is to help doctors in terms of trying to interpret this genetic panel, because most people won't be aware what HLA does or be able to interpret HLA testing. Can anybody here interpret HLA testing? No hands up. Okay, so that's a difficulty. So we wanted to help. So we've developed a clinical decision support system, which is available through the web, or will be available through the web, when the test has been CE marked by the MHRA. And really, so if you want to prescribe carbamazepine to someone, you can just click on that, carbamazepine, and this screen will come up. And this will tell you that carbamazepine, predisposition to carbamazepine is due to two HLA alleles, 31 and 1502. And then if you click this, it will give you a recommendation what to do if a patient's positive for that. It will also tell you the evidence base behind that. It will tell you about the FDA label, the label from the European Medicines Agency. It will tell you about any guidelines and why we're making that recommendation. And then you can, as a doctor, as a prescriber, decide whether you want to do prescribe depending on that test result. So, although at the moment we actually use genetic testing for prediction, i.e. you predict somebody's susceptible, and therefore you don't give them a particular drug, and you give them another drug. However, we feel that you can use genetic tests in many different ways. One of those may be diagnosis. I won't go through all of this, but these are all the different ways you can use the genetic testing. One is diagnosis. So I had a patient on my ward a while ago who had jaundice. And they also had been exposed to a drug called flucloxacillin, which is an antibiotic. Flucloxacillin can cause jaundice in some patients because it causes liver injury. And that's related to a particular HLA allele called B5701. Now, the problem I had was that when I did some tests on her, the patient also had gallstones. Now, was it the gallstones which was causing it, or was it the flucloxacillin which was causing it? So I ran the 5701 test on that particular patient, and that patient was negative for that test. Now, that's important to me because the HLA B5701 testing for flucloxacillin hepatitis has a negative predictive value of 100%. So if you're negative, it's unlikely the flucloxacillin caused the problem. So I was able to refer her to the surgeon. She had a gallbladder taken out, and I was able to tell the GP that she wasn't allergic to flucloxacillin. So should she need it in the future, she could get flucloxacillin. So you can do genetic tests in different ways, and that's very important. So I think as we move forward, the biggest issue that we've got to face in this country and in most Western countries and in other countries as well is the changing demographics. We have an increasingly elderly population, and as you get older, your kidney function declines, your liver function declines, your respiratory function declines, your cognitive function declines, your mobility declines. God, it's depressing, isn't it? At the same time, you're developing multiple diseases, and you're getting polypharmacy. Your doctors are prescribing more and more drugs. It's common for me to see patients who are on 10 drugs, 15 drugs, 16 drugs in my hospital. And you know, the number of patients over 65 who have multimorbidity is increasing all the time. And in China, when the population reaches a maximum, a peak in 2028, they'll have 250 million people over the age of 65. And so it's not just the UK, it's a lot of different countries which have to face this problem. And if precision personalized medicine is going to work, it's got to be able to tackle this. If you can't tackle this, personalized medicine will often be seen as a failure, apart from in niche indications. So that's very important. And so one area we need to think about is, are we dosing people properly in that situation? So a drug which has been tested in a young population or utilized in a young population may have a very wide therapeutic index. And what I mean by wide therapeutic index is that there is a big difference between the dose that causes efficacy and the dose that causes toxicity. However, that drug used in a multimorbid population with decreasing liver function, decreasing renal function, may actually have a completely reverse therapeutic index, very narrow therapeutic index, so that a drug may actually cause severe problems in the elderly when it doesn't do so in a young population. And we need to be able to look at that and how can genetics help with that. And the idea behind this is, can you actually start developing preemptive genetic testing, i.e. that you have your genetic test done at the same time as you have your liver test done, or you have your kidney function test done. I think there was a news item on this at Sunday Express last Sunday. And if you look at some common drugs which are used in the NHS, antiplatelet drugs, statin, warfarin, and thiopurines, which are used for irritable bowel syndrome, and tacrolimus, which is used for renal transplant patients, then you find that some of the things, they all carry variants. And you can see that at least 26% have at least one actionable variant, for example, with this one, and a smaller number have at least one high-risk variant. And if you take those 5 drugs, and then you start looking how frequent are these particular polymorphisms in the population, what you find is that at least 91% have one of these particular actionable variants. So 9 out of 10 of you in this room have one of these variants. And so if you knew about your variant, would you want to be exposed to that drug in the conventional dose? I certainly wouldn't. I would want to have a much more personalized dose for me as we move forward. And so we need to be able to develop evidence base to be able to show how this may be able to help. So people have started doing this. This is a very small trial which was undertaken in the United States. And what they said was that we already have kidney and liver tests before we prescribe. What if we had genetic profiling before we prescribe? And what they did was a small study, looked at patients over the age of 50 years who are on polypharmacy, at least over 5 drugs. And as I said, the trial was comparing 57 patients who received genotyping or pharmacogenetic profiling versus 53 patients who had standard care. And then they looked at clinical outcome measures. And the clinical outcome measures they looked at was basically rehospitalization, emergency department visits, the combination of emergency department visits, rehospitalization, and death. And what they found was that those individuals who were tested with the pharmacogenetic profiling had much better outcomes in terms of reduced emergency department visits, reduced rehospitalization, because they had fewer adverse effects and better efficacy. So the problem with this is it's a small trial, only 57 patients, so it could be a false positive. So one of the things we are trying to do is to actually do a better, bigger trial and try to relate it to the whole of Europe. And we are funded at the moment by Horizon 2020, a project grant, and it's called Ubiquitous Pharmacogenomics. It's been undertaken in 7 countries, EU sites. Liverpool is the only UK site. And the idea behind this is that you provide preemptive genotyping at the point of care to see whether it makes a difference in terms of patient outcomes. And so here's the whole project outlined here. So the first phase has already been completed. Now the first phase, component 1, was where we had to develop the enabling tools, the information technology tools, embedding the information technology into our computer systems so that we can actually show people that there was a genetic variant in that particular patient. We had to develop the genetic typing infrastructure, and it was standardized across 7 countries, and that's been done. We had to make sure there were guidelines, and we used the Dutch Pharmacy Working Group guidelines and maybe modified them sometimes to make it country specific, and also this training and education and ethical issues being tackled at the same time. So the trial is aiming to recruit 8,000 patients, and you either are recruited to the standard care arm or to the genotype arm. You have the genetics available at the point of care when the patient doctor prescribes the drug for you, and at halfway through the trial people will swap, so we can then compare what is going on with standard care versus genetic profiling. And what we're looking at is patient benefits. Does this genetic profiling actually reduce your incidence of adverse drug reactions? Does it reduce your incidence of hospitalization, etc.? At the same time, in component 3, we will also be undertaking some cutting-edge science in terms of doing next-generation sequencing, etc., and so on in these patients. Also, component 4 is ethical, legal, social issues which are going through. So this trial is going on at the moment in Liverpool. We've got to, I think, over 2,000 patients. It only started about April last year. We've got to 2,000 patients. We've still got a few more to recruit, but everything is on track at the moment. So I'm just going to finish off by saying that 50 years from now, where are we going to be? At the moment, I think we're an iPhone 8, unless you were rich enough to have an iPhone X. So in 50 years' time, I think we'll be an iPhone 33. Is that correct? So at the present, we use our phones for global positioning system, GPS. Actually, GPS in 50 years' time will be genomic prescribing system. Your phone will have your whole human genome sequence carried on the phone. It will be linked to your electronic health records in your GP practice, in your hospital, and your lab tests. And you'll be able to prescribe according to genome variation, plus other clinical factors. Okay, so thank you very much for your attention.